Bell tried to use it to teach the deaf people how to speak. It's been any time that you have an activity that you can monitor, you can use biofeedback. Back in the late 60s, it became very popular when the term biofeedback was captioned. What biofeedback is, it's a learning process. Just like learning how to play a musical instrument or play a video game. You're learning something. And you know, biofeedback can be high technology. In our office, we use some technology, we use software programs, but it can be low technology, and it can be no technology. This is a great example. As I was preparing to come do my presentation today, I actually got in front of the mirror and practiced, giving myself some feedback on how I was doing. The best way to teach a child or to talk to a child about how to breathe is to take a jar of bubbles and show them what happens when you take a long, slow breath and blow a bubble, as opposed to you get no bubble. So biofeedback can be done at home, it can be done in a clinic, it can be done any number of places. There's several models that influence biofeedback. There's the drug model, there's the placebo model that we know influences everything. But what I want to talk about are the three that I think influence what we do the most. The first is the classical conditioning, and that's an unconscious learning process that occurs. Classical conditioning is a conditional emotional response. When I was driving over here this morning, I'm going 10 miles over the speed limit. I look in my mirror and what do I see? I see a police officer. What happens? My breath gets really short, my hands maybe start to sweat a little bit. That's a conditioned emotional response. You know, and the model that you have in the handout is the same thing. You go to the dentist, it's time for your checkup. He's working in your mouth and he finds you have a loose crown. He starts messing with it. Oh, that hurts. Then all of a sudden your blood pressure rises. After a number of times with repetition, every time you go to the dentist, whether you're going to incur any pain or not, your blood pressure will rise. We have Skinner's model, which is operant conditioning, and again, that's an unconscious process that occurs. But Skinner gave us a lot of concepts that we use, and the main one is reinforcement. After you reward a certain behavior, the likelihood that that behavior will occur increases. It's an unconscious conditioning. We also use relational learning, and that's where the conscious memories are created so that the clients can call on those memories when they're in their home. Another model that we use is everything that we do in biofeedback is based upon the autonomic nervous system. You have the sympathetic nervous system and you have the parasympathetic nervous system. You have that fight or flight mode. Activities that decrease the body's energy are generated or regulated by the sympathetic nervous system. Activities that increase the body's energy are regulated by the parasympathetic nervous system. Sometimes they do cooperate, at other times they do compete for control. When you see somebody that's having maybe cardiac arrhythmia or hypertension, their body has shifted to a sympathetic dominant state. Whereas when you have somebody that's parasympathetic dominant, maybe they're more prone to something like asthma. Another model that we use is the relaxation model, and a lot of people confuse relaxation training with biofeedback. Relaxation training plays a role in biofeedback. What we try to do is get people to a non-judgmental spot where they can stay focused on the present. And we use relaxation training in our clinic so that people, when they leave the clinic, they can go home and they have something that helps them transfer the skills that they've learned to their home. Because it's not doing you or your patients any good if the only time that they can get relaxed is when they're sitting in my chair in my office working with me. Our goal is to have them be able to transfer the skills and use them at home. One of the techniques that we use for relaxation training is autogenic training. And what that does is it influences the autonomic nervous system, and it can move the autonomic nervous system into a state of balance, and then where there is no competition, where it's all balanced. It also it has to do with muscle relaxation. So let's talk about what an autogenic training session is like. It takes about 10 to 15 minutes, and we'll have someone in our clinic, and we'll kind of have the lights low like this, and I'll say, for the next 15 minutes, I'd like you to sit comfortably in the chair, and after I say a phrase, I'd like you to repeat it to yourself in your mind. And maybe the first phrase I say is, for the next 15 minutes, I don't have to worry about anything. For the next 15 minutes, I can relax. And it goes on and on. I feel my arms being heavy and warm. I feel my legs being heavy and warm. And that creates the muscle relaxation, and it creates an overall state of relaxation. Autogenic training was created by a neurologist, a German neurologist back in the 30s. And what he found is when he observed somebody that was in a deeply relaxed state, they had the same symptoms as someone that was in a sleep. Their limbs were heavy and warm. And he believed that that training could be bidirectional, that he could get someone to passively imagine that sensation, and it would create that sensation. And it does. It works very well. What we usually do is I'll do that with somebody anywhere from 1 to 3 times. Then I'll give them a script, and they'll say, no, I'll just buy a CD. Well, research doesn't support that. Research supports that if it's a live recorded training session, it's more effective. So I'll give them a script, and I'll ask them to record it in their own voice. And I do that for 2 reasons. 1, it increases their skill level, and 2, it increases that sense of internal control, that they are in control. The main misconception about autogenic training, it's training. It's training your body how to self-regulate. It's not a treatment. It's not a pill. It's not one of the many pills that Dr. Oroki talked about. It's a training technique to teach your body how to self-regulate. Doesn't always work. Sometimes it doesn't work. It's a structural issue. Maybe there's not enough time in your training session to really spend working on that. Maybe they don't understand what the training goal is. You have to have a clear training goal. Most critical factor is the relationship that you have as a clinician that you have with your client. If there's not a coaching role involved, and that's where we use wellness coaching, but if there's not a coaching role involved, then it's more of a passive role. And if it's passive, they don't own it. And with self-regulation, it's something that they have to own. There's some personal reasons why it doesn't work. Sometimes we all have that negative self-talk going on in our head, those intrusive thoughts. Some people are afraid of losing control. They want to keep that control tight. Probably the biggest thing that I see is lack of client motivation. They're just not motivated. As much as they want to do it, they can't. And that's where putting them in an active role, getting them to take responsibility for the training is very important. One of the ways that we do that, excuse me, is we use affirmations. Affirmations are just positive statements that people say to themselves that describes the way they want it to be. For instance, I'm saying to myself before I got up here, I'm surrounded by love. How does that make me feel? That gives me a very positive feeling inside. I'm going to be successful in my talk. I'm going to have a great day. They're simple statements. They're not long. And sometimes people will say, well, I don't know what to say. Google it. You can pull up a list of affirmations longer than your arm. But affirmations work. They help you develop a positive attitude. Out of that, you get a sense of personal power. And really what you're developing is a self-discipline. Every day, I'm going to get up and I'm going to start my day with an affirmation. By developing that self-discipline, you develop willpower. And that's key to being able to teach yourself how to self-regulate. It's also a tool that's motivating. You know, the more positive things that you say to yourself, the more you start to believe them. And the first thing I say to anybody that comes to our center is, if you don't believe in yourself, who will? You've got to have some level of self-confidence to be successful at school, at work, in relationships, every part of your life. The next thing I want to do is talk about the different types of biofeedback that we do. And I'll talk about neurofeedback. It's been called neurotherapy, it's called EEG biofeedback, it's called brainwave biofeedback. But it's basically the only way it's different from the rest of the biofeedback that we do is it focuses on the central nervous system and the brain, where the rest of the biofeedback focuses on the autonomic nervous system that we spoke about earlier. So we all know what we have going on up here. This is a bunch of electrical activity. And if you were in the speech earlier on addiction, there was a great snapshot that showed the neurons and the synapses. We've got little neurons, and those neurons have little dendrites. And when they're communicating, they're firing together. And when they touch and they create that synapse creates the rhythm of the brain. And the rhythm of the brain is the brain waves. So what we do with neurofeedback is we focus on the electrical activity in the brain. You, as medical clinicians, you probably are used to looking at the brain this way, the lobes of the brain. We all know what the frontal lobes do. What does the frontal lobes do? That's our executive center. That's where we pay attention, we concentrate, we stay on task, we make good decisions, we're not impulsive, busy little lobes. Then as we go back in the brain, we have the sensory motor strip. And when Dr. Oroki talked about the circadian rhythm, that is set along the sensory motor strip. Every part of your body connects to your brain along that strip. The brain only gets information two ways. You see it or you hear it. If you hear it, it goes into the temporal lobes. If you see it, it goes through the frontal lobes to the occipital lobes. Once that information is in the brain, it goes to the parietal lobes. And that's your master switch. That's where it's broken down in its process. That's where math is done. That's where verbal reasoning is done, nonverbal reasoning, thinking. That's where all the heavy-duty work in the brain is done. I look at the brain a little bit differently. I look at the brain more like this. And there are 19 spots on the brain that we have identified have a job that they're responsible to do. For instance, where you see F7 and T5, when I'm explaining to you what I do with biofeedback, F7 is word recall, T5 is verbal memory. If you've ever had that day when you sit down and you want to talk to someone and explain to a patient what they need to do, and you find yourself, can't think of that word, and you know that word, but you just can't come to mind, your brain's a little out of balance that day. Maybe you haven't had enough sleep. Maybe life's gotten in the way. You know, your kids have stressed you out. Something's happened. But those two spots on the brain, those neurons aren't communicating. When the brain is in balance, and I'm explaining what I do, F7's talking to T5, and I can think of the right word. The first thing that we do when you come to the clinic is we do a QEEG. And what that does is those 19 spots that we identified in the brain as having a job, the cap fits on in your head and has built-in sensors in each one of those locations. Of course, we measure the head, we get the right size cap, and we get it in alignment. Once the cap is on, we're going to record 20 minutes of data. And what we're trying to do is get 10 minutes of eyes open and 10 minutes of eyes closed data when the brain is just in a normal resting state. What I'm looking for when your eyes are open, I'm looking to see beta, both frontal and in the back of your brain. When your eyes are closed, and we'll talk about what beta and the different brainwave frequencies are. When your eyes are closed, I'm looking to see beta in the front and alpha in the back. So I record 20 minutes worth of data, and when I'm recording the data, I'm watching a screen that looks very much like this. And it's very important to pay attention to the raw data, because what we'll do is we'll take that 20 minutes worth of data, maybe I'll use a minute, maybe I'll get 2 minutes out of it, that's perfect data, and I'll take it and I'll compare it, I'll edit artifact. You can see the artifact right there with somebody where they were kind of gritting their teeth. I'll edit and artifact it down, I'll take the perfect data and I'll compare it to a normal database. And that database is gender specific and age specific. And out of that, it will give me a picture of what is going on in the brain. When I look at this brain map, what this brain map suggests to me, I can see this person, and where it's just the light green, that person has just the right amount of activity going on. And this is broken down by hertz, and we'll go into more detail in the next couple of slides on that. But this person is 3 standard deviations overactivated with 7 and 8 hertz activity in the back of the brain, the parietal lobes and along the sensory motor strip. Well, what do the parietal lobes do? That's where our cognitive processing is done. What this brain map suggests to me is somebody has issues with cognitive processing. A lot of times people come in and they say, well, you know, I've got ADHD and I know it's just that I can't focus. And we do some other tests that show us they can focus just fine. They can't process. They can't break the information down and use it. And it results in, of course, them not being able to focus or use the information. The brain map also shows me that there's overactivation in the frontal lobes, 3 standard deviations overactivated of 13, 14, 15. Because of where that overactivation is, I know that their ability to stay on task, finish what they start, pay attention, concentrate, working memory, ZFZ, all of that's probably it. They're not able to do that as well as they should. And a lot of times people say, but you know, Leigh, when you talk about beta, you talk about this activity. So that's the good stuff, right? And I've got too much of the good stuff. So I'm good. And I'm like, no, too much, not enough, it doesn't matter. When the brain is out of balance, it cannot work the way that it should. That's what it comes down to. So I want to talk a little bit, explain the different brainwave frequencies that we look at when we do that mapping. When you're asleep, your head is total delta, big slow waves. When you're going into that sleep or coming out of that sleep, you're in what we call a theta state. And that's that kind of foggy state where, you know, your spouse may say, come on, come on, come on, you gotta get up. And you're just like, oh, 5 more minutes, give me 5 more minutes. That's a theta state. And theta is dominant in the frontal lobes in the central region. So classic ADHD is someone that has too much slow wave activity in the frontal lobes. Then you have alpha, and alpha is a good brain wave if it's in the back of your head where those O's and those P's were on that chart, and your eyes are closed. Alpha has a job to do in the brain, and that job is when you close your eyes, that nice peaceful, contented feeling that you get before you go to sleep. That's what alpha is responsible for. Too much alpha on your left side frontal, F3, will create depression. Too much alpha along your sensory motor strip can create anxiety. So alpha is only good when it behaves and it stays where it should. Then you get into your processing power, and we have what I call low beta. And if low beta is along your sensory motor strip, it's called SMR, which is what you see on the slide. It's the same thing. And that's your calm processing power. If you've ever known somebody that, when we all have problems every day, I have a problem, you have problems, it's just part of our everyday life. But if you've known somebody that it doesn't matter how big the problem is or how small the problem is, they react. That reaction can be anger, tears, shutdown. They don't have the right processing power. They can't calmly think through the issues. Okay, my computer won't work. Let me think. Let me turn it off. Let me reboot it and see if that doesn't fix it. So that's the responsibility of the low beta. And a lot of times, people with anxiety just don't have enough low beta. They go from a slow wave state right into a fast wave state. And then you get into your beta waves, and the 15 to 20 hertz activity is your main processing power. How many of you have ever gotten into a car and the battery's dead? And you turn that key and just, it won't turn. That's what a kid that has ADHD or an adult feels like if they don't have enough processing power and they sit down at school and try to perform, or they're at work and they try to do a project plan. They feel exactly like that. And then you have high beta, which is a real fast wave, and that doesn't really add any value to your brain. It just creates irritability, anxiety, and dysfunction, no matter where it is. So we look at the brain as in terms of where the activity is going on, the lobes that we looked at, and then we look at it in terms of what's going on, what type of frequency is going on, and then do you have too much, not enough, or both? And it's not unusual to have not enough and too much all going on in different spots of the brain. So from that information, we're able to determine where we need to train and what we need to train. So we do that. The cap is a little invasive. Usually after you've had that cap on your head for 20 minutes, you're ready to get it off. But the neurofeedback training is not. The sensors, as you can see, are very small. They're smaller than my little fingernail. And we'll put anywhere from 1 to 4 sensors on your head. We can train up to 4 channels at the same time if we want to. And what those sensors do is they monitor the electrical activity that's going on underneath the scalp. And what it's all about is creating self-regulation in the brain. And we'll talk about what happens in the neurofeedback session. The brain loves to learn. It's easy to create change in the brain. The hard part is creating the right change and getting the brain to hold the change. And you do that just like if you want to build up your big biceps. Any muscle that you work, what does it take? Repetition. Over and over and over. And that's why generally with neurofeedback or EEG biofeedback, it'll take around an average of 20 sessions to get the brain to retain and hold that change. Each training session is about 20 to 25 minutes long. So let's talk about what happens in a training session. As a clinician, this is what I'm looking at. This is the screen I'm looking at. Someone sitting on the other side of the desk is looking at something different. As a clinician, I'm looking at 3 things. First, I'm looking at their brain waves. I'm watching those. I'm making sure that I don't get any impedance or I don't lose the level of contact that I have. Second, I look at what I'm training. On this, what I'm training here is I'm trying to decrease the alpha, decrease the beta, and decrease the high beta. This represents somebody that's anxious, that has too much fast wave and is anxious. In addition to that, I'm looking at this box over here, and this is ratios. Because as I said, it's easy to create change. You want to create the right change. Let's say I get rid of the high beta and the beta, but I make more delta and more theta than that person needs. So then I take them from an anxious state to a depressed state. That's not where we want to go. So it's all about monitoring and watching the change as it occurs. And we train real time. It's very normal that we'll pause a session in the middle because we'll see something change and say, I'm going to modify this. I'm going to add in another protocol, and that's exactly how that alpha protocol got added in. We can see what's happening. So as a clinician, that's what I'm looking at. As a client, you're looking at a movie screen. You're looking at a monitor. Maybe it has a movie on it. Maybe it has a video game on it. That's up to you. But when you're meeting your thresholds, and a lot of times we'll put those little thresholds on their screen too so that they can link, what's happening to what's causing it. When you're meeting those thresholds, you get your reward. Let's say you're watching a movie. You're sitting there and you're watching your movie and you're meeting your thresholds. You can see the movie. You stop meeting those thresholds, the brain starts going above it, and the movie gets black, and the movie just fades away. The brain's like, hey, wait a minute, I want to see that. I'm watching that movie. So it will automatically self-regulate and start to repattern. I'll do this. No, I'll do this. No, I'll do this. Oh, that's what I need to be doing. The movie's back. At the same time that you get that visual reward, you get an auditory reward. And that reward is a beep or a click. And a lot of times people say, Leigh, could you turn that off? It's very annoying. And no, I can't. Because it's a stimulus. It's a stimulus to the brain. Let's say you come and you do 5 or 6, 7 sessions, and you used to get anxious 2 or 3 times a day, and now you're only getting anxious 2 or 3 times a week. But you're always going to have something in life that's going to make you a little anxious. And when you start to feel that way, listen for your beep. Play that beep in your brain. And when the brain hears that beep, what does it do? Oh, what am I doing up here? I need to be down here. And it will automatically self-regulate down. So as a client or a patient, you're getting rewarded both visually and auditory. At the end of each session, we look at a chart and we show you the change that you've made. Of course, over a number of sessions, what we're looking for a percent of change. We're looking for changes in your ratios from each session. So that's what neurofeedback is. I'd like to talk now a little bit about respiratory biofeedback. And that's just breathing. And as simple as it sounds, it's not that easy. We all take about 20,000 breaths a day. And usually, men take 12 to 14 breaths a minute, women take 14 to 16 breaths a minute. Optimal breathing is anywhere from 5.5 to 7.5 breaths a day, slowing our breath down. So with neurofeedback, we put sensors on your head. With respiratory feedback, we put a band around your waist that's got a sensor built in. and it measures how you're breathing. And the screen for that, well, before I show you the screen, I'll talk about why that's important. We know that shortness of breath is related to heart disease. We also know that there's a high correlation with high blood pressure and your breathing. Breathing drives your whole nervous system. It promotes weight loss, oxygen burns calories and fat, and it's the key to sleeping well. That's the one thing that people say first thing they'll say when they start doing neurofeedback is, I'm really sleeping well, or I'm dreaming now, I never used to dream. And what that shows you is that you're creating change in their brainwave patterns, which creates change in their sleep patterns. So now we'll look at a screen, biofeedback screen. What we're seeing here is we're seeing two types of breathing. How's the best way to breathe? Who knows what the proper way to breathe is? Absolutely. Pulling your breath in through your nose down into your abdomen. And that's what we call diaphragmatic breathing. How many of your patients do you see when you walk in and you talk to them, and they're real short of breath and they can hardly catch their breath? They're thoracic breathing. They're breathing with their chest. Look at the difference in that. Look at those short, choppy little rates compared to the smooth, even breathing. Where this gets real interesting is when we're going to talk about EMG, which is muscle tension. When you're breathing like this, look at the tension it creates in your trapezius. Whereas when you're breathing like this, in a smooth manner, look how much more relaxed your trapezius muscles are. So the first step that we do in our clinic is we try to teach people how to breathe properly. And that's number one, becoming aware. Think about how you breathe. Take your left hand and put it on your chest, and your right hand and put it on your navel. And if your both hands are going up and down at the same time, you're breathing thoracic, you're breathing in your chest. And that's not the way you want to be breathing. Once we teach people how to breathe, just on a very, slow your breath rate down. The best place to practice is driving, because there's nothing else to do. That's what I do. When I'm driving, I'll think about my breathing. Once we can get your breathing in sync, then we can get that in sync with your heart rate. And I really believe that in the next 5 years, heart rate variability will be something you, as doctors, check, just like you check a pulse and blood pressure and weight. In the last few years, there's been over 2,000 studies that have been done on heart rate variability. And there's a great website called HeartMath that's got a lot of that research on there. And what heart rate variability does is it looks at your heartbeat beat by beat. And if you can get your heart rate in sync with your breath rate, then you create wellness in the body. Just to go back for a second, what happens when you're feeling frustrated and anxious and stressed? Look at that heartbeat. Look at what it feels like when you're feeling love and compassion and gratitude. Very, very different. So I really predict that in the next few years, that'll be something that you use in your practice. And it's something that people can do at home as well. I want to talk a little bit, I mentioned muscle tension, EMG, and most people that come in that have tension headaches have tension in their forehead or tension in their masseter. They have some, they clench that jaw. What we do with EMG is, again, we use sensors, and everything that goes on in our body is electricity. The muscles are putting out electricity. They're putting out ions. And those ions, when the muscles are positive, they contract. And so what we do is we measure the activity, the muscle waves from the muscles. And we look at it in amplitude, wavelength, and frequency, very similar to the way that we look at brain waves. And we can graph it in time and frequency. This is a clinical application of EMG, and it's for someone that's got anxiety, stress, tension type headaches. We put 2 sensors there, and the first thing we do is we show them what muscle tension is. Raise your eyebrows, wiggle your forehead, and see what that does to the screen. And once you become aware of how you're creating that tension, you can teach yourself to relax and release that tension. Okay, I'm gonna move. I've got 5 minutes. We also do work with the sweat gland, EDA biofeedback, and temperature biofeedback. There is research behind what we do, and I think most people say, hey, that sounds good, sounds great, sounds kind of hokey pokey to me. It's not. It's clinically rated on an efficacy scale of 1 to 5. AAPB puts out a book, chronic pain, epilepsy, headaches for adults, on a level 3. You've got insomnia, addiction, traumatic brain injury, headaches for pediatrics. And the only thing that I disagree with is they rate for depression and PTSD, they rated a level 2. It's due to be reviewed again. It's 2012, this was 2008. And I have to tell you, in the decade that I've been doing this, for depression, it's closer to a level 4 in my experience. And for PTSD, it's closer to a level 3. So just very quickly, how do you apply this? And as I mentioned before, one of the first things that people say when they do neurofeedback and biofeedback is, gosh, I'm sleeping so much better. You know, I'm really sleeping well. So we've taken it and we've applied it to how we can use it with insomnia. And there's so many sleep studies out there. I probably looked at 50 sleep studies, identified 21 that I found were interesting. Out of those 21, 15 had been published in the last 5 years. Some of those deal with biofeedback, neurofeedback. What those studies found, and just to summarize, is the importance, as Dr. Oroki said, of a cognitive approach. Research supports EMG and EEG biofeedback to be effective ways to train it. And evidence that the hyperarousal, that overactivation that we looked at in the map, is implicated in insomnia. Most people that I work with that have insomnia have too much fast wave activity going on. We have a 4-week program. Our goals are to increase the total sleep time and daytime awareness. So we do that. A lot of the things Dr. Oroki mentioned, sleep logs, trying to identify the bad behaviors that they need to change, and that's really the hard part. Establishing some sleep restriction guidelines, doing the relaxation techniques that we do, doing some neurofeedback, doing some EMG, and with that we're able to create the change. Does it work? It does. Our biggest challenge is changing the habits around sleep. People don't want to, you know, no, I like to have my light on. I don't want to turn my light off. And as Dr. Oroki mentioned, it's not just about sleep. I think he said 50% of the people that have insomnia also have psychological issues. The hard part is keeping focus on the sleep goals, because instead of, you know, it goes from insomnia to depression, from depression to anxiety. And of course, the key is creating lifestyle changes. And again, that's how we use wellness coaching as part of the training that we do. So to stay on track, we are finishing. If any of you have any questions and answers, my colleague Sally Cocan is here with me. Stop by the booth, grab one or either one of us, and we'll be happy to answer any questions that you have. Thank you so much.